for those who need it. It is my pleasure to now introduce Dr. Jabulile Mary Jane Jace Mavuso, who is a postdoctoral researcher in the sociology department at the University of Pretoria and book reviewer editor for feminism and psychology. They hold a PhD in psychology from Rhodes University, where they are a research associate for the critical studies in sexualities and reproduction research program at Rhodes University. And his research interests are in sexual and reproductive politics and the narratives, discourses, and power relations underpinning them. His recent publications are a special issue on reproductive violence, co-edited with Dr. Rochelle Chadwick, published by Agenda, and a book, Sexual and Reproductive Justice, From the Margins to the Center, co-edited with Dr. Tracy Morrison and published by Rowan and Littlefield. It is my pleasure now to introduce Dr. Mavuso, and the topic he's going to be discussing is men and masculine people's pregnancy desires and experiences. So Jabu, over to you.
Hi, everyone. Can everyone hear me? Cool.
Yes.
Cool. Okay, thank you, Jason, for that introduction. Let me just share my screen.
Oh, wait, I have to make you co-host.
Okay.
Sorry. Yes, I think you should be able now.
Cool. Okay. Oh, sorry for the delay. Okay, so I've actually, my keynote address has actually changed slightly, well, not slightly, significantly. Okay, so it's now entitled Moving Beyond Cis Women, Gender and Sex Diversity in Pregnancy Desires and Experiences of Pregnancy-Related Healthcare. Okay, so just to introduce myself a little bit, very briefly, in addition to what Jason has said, just a bit of a brief personal introduction. So I am a trans non-binary person who has a uterus, and my work recently has been thinking through the ways in which I am positioned within these spaces, or invisibilized within feminist work and activism around pregnancy-related healthcare, reproductive oppression, and then more broadly, how trans folks are also the different ways that trans folks more broadly are positioned within these spaces. And I'm also increasingly incorporating into my work, thinking through how intersex folks are positioned within these spaces. Right, okay, so to introduce the keynote, kind of brief, kind of overarching introduction. It's, I suppose my recent thinking is about reflecting on the ways in which cis women and endosex, i.e. non-intersex women have for a while and largely continue to be centered in pregnancy-related research, activism, and healthcare. And my keynote really is about the imperative of recognizing the sex and gender diversity of pregnant people, of people who want to be pregnant, and people who have uterus, and the imperative to ground our knowledges and practices, whether we're talking about research, activism, education, and healthcare, in that recognition, in the recognition of this diversity, sex and gender diversity. And as part of this keynote, I'll be discussing the limitations and harms of a cis endosex woman-centric approach, the harms for intersex and trans folks with uteri, and then also give some of my own brief reflections on the kind of possibilities that could be opened up in terms of how we humanize birth care and how we humanize pregnancy-related care more broadly once we incorporate and in some way start from this recognition of this diversity. Just a brief note, I will be speaking of pregnancy-related care more broadly, rather than focusing on birth care only. And then lastly, it's kind of framing this keynote is that I suppose it's kind of note that the call and imperative to decenter cis women and endosex women in how we understand pregnancy and also in how we care for pregnant people is really about including us all. Within these spaces. Something my sister says quite often is about how we often think that and we're made to think, because of systems of power, we're made to think that there's limited space in the sun. And the sun here, I'm speaking about, metaphorically as the reproductive freedom and the reproductive future centered on freedom that we're trying to create and ensure. We're made to believe that there's limited space in the sun, and that this limited space means centering some folks, prioritizing some folks' needs, and excluding and marginalizing other folks. And really this call to decenter cis women and to be inclusive is about recognizing that there is space for all of us. There must be space for all of us. There is space for all of us. So it's not an either or situation. It's not about prioritizing one person over another. It's about sharing the space, sharing the reproductive future we are trying to create. Sorry. Okie dokie. So just a bit of I suppose, a background, or by way of a kind of background, on the ways in which feminist and reproductive spaces, but also knowledge, even when it's not explicitly feminist or not grounded in feminism. On this idea of, this idea really that is replicated in various spaces of how we have feminized pregnancy. Okay, so feminist work on reproductive oppression, by and large, research, activism, knowledges that are produced tend to construct pregnancy as an embodied experience that cisgender endosex women are uniquely capable of and are the only ones who are capable of, right? So cis endosex women are tend to be understood as unique in having a uterus, unique in experiencing pregnancy, unique in needing pregnancy-related healthcare spaces and in using these spaces. And really, pregnancy has become conflated with cis womanhood, endosex womanhood. And this can be seen, for example, in the ways in which pregnancy-related rights are often framed as women's rights exclusively. And, thinking about the work in reproductive oppression from feminist approaches is that even when, feminist scholars, some feminist scholars recognize that people with uteruses and pregnant people include more than just cisgender endosex women, the tendency is sometimes still to center cis endosex women and to set them apart from, other folks with uteri, other pregnant folks. So, for example, this is evident in phrasing, for example, such as women and pregnant people, women and people with uteri, women and birthing people, or women and birthers, etc., etc. And part of this is really reflecting on that particular usage, because terms like pregnant people, people with uteri, birthers, birthing people, or menstruators are already inclusive. And trans scholarship has really, and intersex activism has really, led the way in the sense that these terms are already inclusive, and so they already at the outset include cisgender women. They already at the outset include endosex women, and so it's about reflecting on, the need to still center cisgender women by setting them apart, even in terminology, even when using terminology that is supposed to be inclusive or that is already inclusive. Okay, and then, in terms of bioethics discussions, I've been looking at that as part of my research on cisgender men's desires to be pregnant, to be gestational parents. I've been looking at this, this area of writing really as one of the spaces where cisgender men's desires to be pregnant are discussed. And that's kind of been my entry point. And I've been looking at the similar ways in which pregnancy is constructed in feminist work on reproductive oppression and, very specific bioethics discussions on womb transplant technology, particularly in terms of who the recipients of this technology should be. Okay, so even, similarly within the bioethics discussions on womb transplant technology, there is a similar conflation of cisgender endosex women with pregnancy. This continues in this, these bioethics discussions on womb transplant technology, and which is a technology that could and should, I argue, enable pregnancy and gestational parenthood for whomever wants it, right? But interestingly and importantly, within these discussions, and I'm speaking of them very broadly, there are some variations with, there are more critical discussions, which are grounded in inclusivity to varying extents. But interestingly and importantly, within these discussions, cisgender endosex women are positioned as the primary and obvious, very much so the taken for granted recipients of womb transplant technology. If it were to be rolled out and available beyond the kind of trial phase where it is in, cisgender endosex women are very much so seen as the primary and obvious taken for granted recipients. their desires for pregnancy and gestational motherhood, and the importance of their desires, of cisgender intersex women's desires within these, writings, within the scholarship, is taken for granted, as, it's obvious, it makes sense. And really their desires are afforded a weight and profound meaning. And of course, this is not, my bringing this up is not to discount that weight or to undermine those desires. It's simply to note the very different ways in which different groups of people's desires for pregnancy, to be pregnant and to be gestational parents, how those desires are treated very differently. So then, comparatively speaking, trans women, when they are discussed within this kind of bioethics sphere, when their desires are discussed, when they are brought up, which is rare, trans women tend to be tentatively included. A very kind of, conditional inclusion, tentative inclusion, and tend to be included on the basis of the assumed importance of motherhood for womanhood. At the same time, trans women's desires, potential desires, existing desires to be gestational mothers, to be pregnant, tend to be trivialized, not afforded the same weight that cisgender intersex women's desires are. Then continue with this kind of comparative kind of, discussion. Trans men tend to be mentioned, also when they are mentioned, tend to be mentioned in comparison to cisgender women, in comparison to trans women. They tend to be mentioned as easier recipients, from the point of view of already having a uterus or presumed to already have a uterus, right? So within these discussions, there is a lot of homogenization of trans folks. But apart from being a kind of easier candidate, trans men aren't assumed to want to be pregnant within these bioethics discussions, and aren't assumed to require womb transplant technology. And then cisgender men, as a kind of last group that is considered within these discussions, their desires are largely, or cisgender men are largely precluded, discounted as womb transplant potential recipients, with their desires being constructed as non-existent or hypothetical or strange or superficial or contradictory to their gendered identity as cisgender men. So within this discussion, really what emerges within bioethics discussions, what emerges is an idea of cisgender intersex women as being the only ones who would require womb transplant technology, and their desires are the only desires that are really given any real weight and meaning. Okay, so now just reflecting on feminist work and bioethics discussions, and what connects the two is really kind of colonial and patriarchal ideas about pregnancy, ideas about gender, ideas about sex, and the relationship among these. Understanding human beings as divided into two categories, as male or female, man or woman, social parent or gestational parent. And within this kind of patriarchal, colonial, sex gender system, pregnancy is constructed as feminine and is sexed as cisgender female. So a pregnant person is imagined to have to necessarily have a vagina, to have a uterus, to have breasts, and they are gendered as feminine. And then male bodies are constructed as without the uterus. And while women within this framework are seen as pregnant, men within this framework are seen as necessarily non-pregnant. So this has, meant, this kind of feminization of pregnancy has meant that maleness and masculinity have been essentialized as non-uterine and non-pregnant. And this is really reflected and replicated in how we speak about and understand pregnancy, sex, and gender in our everyday lives, but also in our laws, policies, medical knowledge, and healthcare practices, which is something that Toes really powerfully demonstrates and argues in his article, which really draws on the UK context and speaks to the UK context, and really speaks about how there is a social and medical and cultural preference for trans men in the UK to undergo hysterectomies, based on the assumption that trans men and trans masculine people won't want to be pregnant, won't want to be gestational parents. Coming back to the idea of masculinity as, in terms of our dominant understandings, patriarchal understandings, colonial understandings of masculinity as non-gestational. And then Korean really speaks about how part of this kind of, colonial and patriarchal legacy of thinking about sex, gender, and pregnancy is this socially constructed entanglement of sex, gender, and pregnancy, where people with uteri, people who are pregnant, people who want to be pregnant, are defined within our discourses, are defined as cisgender females, are defined as cisgender women, are defined as feminine, and how this stems from repronormativity, a system which privileges some kinds of reproduction and reproductive practices and privileges certain people as legitimate reproductive subjects, based on ideas of what counts as normal, natural, desirable reproduction. And Korean argues and shows how these ideas of what is, of repronormativity abnormalize and preclude male pregnancies. Okay, so this kind of critical approaches that interrogate the relationship between sex, gender, and pregnancy, and the colonial and patriarchal legacies that show up in our everyday understandings of them, really emphasize that the conflation of women with pregnancy is harmful for all of us. It harms all of those who are not women and who do get pregnant by constructing our pregnancies as abnormal, immoral, unnatural, impossible, risky, dangerous, or by invisibilizing us, or by misgendering us as women, right? Treating us, seeing us as women, because women are supposedly the only ones who, women are the only ones who expected to be able to be pregnant and to get pregnant. But it also harms cisgender intersex women who do not want to or cannot become pregnant by framing them as lesser women. It harms trans women, whether or not they want to be pregnant, by similarly understanding trans women as lesser women. And really comes back to the construction of women with uteri as women proper. Which of course harms cisgender intersex women who have no desire to be pregnant or who cannot become pregnant. Okay, so just speaking briefly, well, not briefly, but speaking to, sorry, some of the harms of this feminization of pregnancy and of sexing pregnancy as necessarily female, cis female. First looking at some of the lessons from intersex activism. So Interact and Lambda Legal produced a document on how to provide intersex affirming and humanizing care. It focuses mostly on coercive intersex surgeries that are still routinely performed on intersex infants. And it also focuses, the document focuses on general care provided to intersex folks. And although it doesn't focus specifically on pregnancy-related care for intersex men, women, and non-binary folks, I've drawn on it here as the violences and harms documented in this document are likely to be replicated in pregnancy-related care for intersex folks with uteri. And thus, these kind of lessons do need to be considered in our conceptualizations of birth care and pregnancy-related care that is humanizing, that humanizes. Okay, so the document speaks to the ways in which, or describes intersex folks' experiences with general care, but as well as reproductive care, and how they tend to be or have been exoticized and objectified during the course of receiving care, this being perpetrated by healthcare providers. So, constructed as strange and abnormal, or positioned as strange and abnormal. And this, the document reports how this can take the form of intersex patients being exhibited, right, to medical students. So in the training of medical students, intersex patients may be exhibited without their consent and also unnecessarily, and often when it's unrelated to the care that the intersex patient is actually requiring at the moment. It also can take the form of, some intersex patients reported how healthcare providers would expect or demand or request intersex patients to teach them about intersex anatomy or intersex anatomies, recognizing the variations, diversity, instead of, doing that preparatory work themselves. Doctors or healthcare providers more broadly would use that healthcare interaction as a learning environment and expect to be taught. And then, really both of these, the document points to how both of these deny the privacy or the right to privacy and the right to autonomy of intersex patients. The report also documents how intersex patients are subjected to harassment and disrespectful language used by healthcare providers. So healthcare providers commenting on intersex patients' bodies while providing so-called care. Men also misgendering because of assuming, coming back to this idea of the feminization of pregnancy, because of assuming that pregnant people are necessarily cisgender women. Intersex patients reported being misgendered in the course of receiving healthcare. And then also some patients reported violent medical practices as part of the being subjected to that during the course of receiving care. So unconsented and unnecessary touching and examinations, which of course are forms of assault that are kind of routinized, not kind of, that are routinized. Okay, then switching to lessons from trans research. Some of the trans scholarship has really documented trans men and trans masculine and trans non-binary people's experiences of cisnormative pregnancy-related care, care that ranges from abortion to conception, trans folks' attempts to conceive pregnancies, but also care that includes antenatal care and then birth care. And this work really documents the ways in which providers often enforce the patriarchal gender binary. So Falk's study, which was conducted in Sweden, documents how trans men and trans masculine folks reported misgendering as part of this enforcement of the patriarchal gender binary, being misgendered. Pregnancy was, during the course of consultations, pregnancy was also constructed as something that is inherently incompatible with the masculine identity, and trans men and trans masculine folks and trans non-binary people reported how their identity was questioned or trivialized by healthcare providers because of the fact that it was perceived to differ from, or because of its departure from, patriarchal ideas about what masculinity should look like behaviorally and in a bodily sense, because it disrupts that idea of masculinity, that colonial and patriarchal idea of masculinity as necessarily non-uterine, non-gestational, non-pregnant. And then other experiences really speak to how pregnancy-related healthcare spaces are constructed as women's spaces, and the invisibilization and exclusion that occurs because of this construction. So Riggs' study is an Australian one, and speaks to the ways in which some trans masculine and non-binary folks speaks to their experiences of trying to conceive and accessing fertility clinics, and reports on their experiences of being denied access to fertility clinics, despite having purchased sperm and brought sperm with them to be inseminated with, but they were denied access to some fertility clinics because these clinics wanted cisgender male-female couples only, were only serving those couples. And then some participants reported accessing fertility clinics that were recommended by friends and family and acquaintances, that were recommended as queer-friendly, and yet some trans men and trans masculine and non-binary folks were alienated within these spaces that were supposedly queer-friendly. In Falk's study, some trans men and trans masculine participants reported not being attended to when they presented at a hospital pregnant and in labor, reported not being attended to initially, and then receiving very delayed care because healthcare providers failed to realize that they were pregnant in the first place. And in one particular example, one of the participants speaks about how this kind of interaction where their friend, they went with their friend to the hospital, their friend who was pregnant and in labor, and while their friend went and waited, the friends took it upon themselves to go speak to healthcare providers because their friend, he still hadn't been seen, and they said, our friend is in labor, like the baby's, coming, he's pregnant, he's in labor. And healthcare providers were entirely thrown by the use of he, the he pronoun, to describe the person who was in labor. And that was part of the whole delayed care. Right, okay. And then Merson and Falk point out how pregnancy-related healthcare has really been conceptualized and designed with cisgender, intersex women in mind, and it's been implemented that way. From the decor to informational posters, signs, and labeling within reproductive and pregnancy-related healthcare spaces, to the use of exclusionary terminology for procedures, to intake forms and patient records that only expect cisgender, intersex women to walk through the door, and are only really prepared to cater for cisgender, intersex women. Okay, and then Luvuno et al.'s study, which is a South African-based one, really is more broadly looking at reproductive and sexual healthcare, and access to contraception. And this really echoes some of the findings with Interact and London Legal's document about participants being exoticized and objectified during healthcare interactions. And then lastly, this really research point, what came up is a lack of provider knowledge of transgender pregnancies. So, for example, in Falk's study, participants, reported wanting a C-section, but not knowing whether gender dysphoria would be recognized by healthcare providers as a valid reason to have one. And so they ended up having a vaginal birth, even though that was not what they wanted to do. And then also some trans men and transmasculine people reported that healthcare providers dismissed gender dysphoria as a valid reason to not chest feed, to not breastfeed, on the one hand, while on the other hand, trans men and transmasculine people who had previously undergone gender affirming care and who did want to chest feed and breastfeed weren't able to, because healthcare providers were unsure of whether they would be able to, biologically speaking. Okay, so kind of thinking through what it means for me. These are really just my reflections and thinking through what it means for me to humanize pregnancy and to humanize pregnancy-related care more broadly, and thinking about the limitations of a cis women-centric frame and the possibilities of a sex and gender inclusive frame. And thinking about how I've kind of, structured my keynote, focusing on not only birth care experiences, has really allowed me to speak to intersex and trans men and transmasculine and trans non-binary people's experiences that I would otherwise miss, and that I would otherwise exclude, but which still have consequences and implications for birth care specifically, and consequences for how we need to think through our attempts to humanize this care and what humanizing pregnancy-related care and birth care specifically means. It has also allowed me to reflect on, important feminist legacies, such as the theorizing and activism around obstetric violence. And while I was preparing this keynote, I've noticed some of the same harmful practices that are described and documented by cis women being reflected in intersex and trans folks' experiences. And I thought about how thought about how the patterned absence of intersex and trans people's experiences within feminist theorizing on obstetric violence, for example, this patterned absence is not an evidence of absence. It's not an evidence of the absence of these harms in intersex and trans lives. And from this point of view, delivering my keynote in this way has really made me think about how recognizing the human diversity of people with uteri and pregnant people presents us with an opportunity not only for building connections in our activism, but also to expand and distill our theories. So in one sense, the harms that intersex and trans folks are subjected to, that is really documented in activism and research, the harms that they're subjected to in pregnancy-related care, including childbirth, and their experiences of obstetric violence that have been reported by cisgender women are all connected by the continued entanglement of sex, gender, and pregnancy. Specifically the feminization of pregnancy and the sexing of pregnancy as cis female. I've been thinking about how pregnancy-related care in its current iterations serve to enforce medical patriarchal ideas about pregnancy and womanhood, and the different ways in which these harms different groups of people, different groups of pregnant people, but the ways in which it is harmful for all pregnant people, and the connections between different groups' experiences. In another sense, the harms and violences that intersex and trans people who seek to become pregnant, or who are pregnant, or who are trying to avoid pregnant, or who are trying to stop being pregnant, point to the need to humanize pregnancy and what it means for me to humanize pregnancy, and point to the need for the humanization of pregnancy to be part of our efforts to humanize pregnancy-related care. And humanizing pregnancy, for me in part, or at least in this sense, humanizing pregnancy is about recognizing and being informed by the full human diversity of people with uteri and the full human diversity of pregnant people. The harms that are, that intersex and trans people are subjective to in pregnancy-related care are also reflected in repronormative ideas, and in the repronormative privileging and valuing of some people's gestational reproduction, and the invisibilization and devaluation of other people's gestational reproduction. So I've been thinking about how, starting from a recognition of the sex and gender diversity of people with uteri, perhaps enables us to realize the connections between different groups' experiences of pregnancy-related care, the connections and the similarities, but also the differences where they emerge, where they are apparent. Recognizing the sex and gender diversity of people with uteri, of pregnant people, of people who access and use pregnancy-related care will also enable us, I think, to reimagine and implement pregnancy-related care that is not grounded in gender norms and sex norms, but that is instead grounded in upholding the dignity and grounded in honoring the personhood of all people who require this care currently and all people who will require this care, particularly if womb transplant technology is made accessible to anyone who wants it. And I suppose that what I've also thought about is how humanizing pregnancy might result might make us think differently, more expansively about what it means to humanize pregnancy-related care, that made me think about how a care that recognizes the human diversity of those who do and may one day use pregnancy-related care is a care that is attuned to this diversity, is a care that anticipates and expects this diversity, a care that welcomes this diversity, and a care or a set of services then that is therefore able to care fully for all people who walk in the door. Okay, very lastly, and kind of briefly, just wanted to reflect a little bit on my own research and I suppose where it fits in research and scholarship that forces us to interrogate our understanding of sex, gender, and pregnancy. And, you know, really reflecting on the feminization of pregnancy and the sexing of pregnancy as cisgender female, and how it not only shapes the kinds of care that is available to pregnant people, or the non-care that is provided, but it also shapes the kinds of research we undertake, the questions that we ask, the questions that we dare to imagine and dare to ask. And, you know, going back to the womb transplant discussions in bioethics, I'm struck by I've been struck by in the course of doing my research on cisgender men's desires to be pregnant and or be gestational parents, I've been struck by how the cis feminization of pregnancy has, you know, thoroughly shaped who we imagine wants to be pregnant, and has shaped how we understand gestational desires and how seriously we take different people's gestational desires. And in a sense, my research on cisgender men's desires to be pregnant was about refusing to preclude cisgender men's desires to be pregnant and to be gestational parents. The project was premised on the idea that just as there are many people with a uterus who do not want to be pregnant and or be gestational parents, there are many people without a uterus who do want to be pregnant and who do want to be gestational parents. And my thinking was really there was no reason why cisgender men would not be part of a group of people who don't have a uterus and who nevertheless want to be pregnant one day, or have wanted to be pregnant at some point in their lives, and or want to be gestational parents. So in formulating my research, my question was not, are there cisgender men who want to be pregnant and or be gestational parents? You know, my question was not, do they exist? I took it for granted that, of course they do. So instead, my project sought to visibilize their desires. And instead I asked how cisgender men narrate their desires, how they speak about their desires, what subjectivities are created in their narratives. Do the men break with or continue normative understandings of pregnancy, sex and gender, parenthood, etc.? And this kind of, well, my research really, I see it as being made possible by the trans scholarship that has come before it. And this scholarship that really visibilizes the human diversity in pregnancy experiences and the consequences of failing to appreciate this diversity. And I have been honored to have been part of this tradition. I see this, my own research as being part of this tradition of, you know, challenging the idea that cisgender masculinity is the absence of gestational desire, is the absence of a desire to be pregnant, to be a gestational parent. And just kind of briefly, part of what I found really important in my research was the diversity I was able to, limited, albeit limited, but the diversity I was able to capture among my participants. Some of it was a very small sample of participants. It was 6 cisgender men, but they were of diverse identities. It was conducted in South Africa, but then broadened out later. So 5 of the men live in South Africa and work in South Africa, and 1 in the UK. Some of the men had, at the time of the study, had children already, young children and some adult children. Some men did not have children at all. Some men were partnered, and of those who were partnered, most were described being in a relationship with a cisgender woman, and 1 participant self-identified as gay and was in a relationship with a man. And participants were also varying ages. 1 participant was in his 50s, and the rest were younger. Yeah, and so, I mean, even just at the identity level, it really, what I found really important was how it challenged, that idea, going back to the womb transport technology, the idea of, in some of the discussions there, when cisgender men's desires to be pregnant are recognized, it's certain cisgender men are imagined as being the ones who are most likely to want to be pregnant. Specifically, gay men have been, spoken about, gay cisgender men have been spoken about as being most likely, if any cisgender man is going to want to be pregnant. The expectation is that the kid might be gay cisgender men. And so my participants and their identities really kind of challenges this idea, preconceived ideas we have of who wants to be pregnant and which cisgender men might want to be pregnant. And yeah, there was a diversity in their desires as well. Some of the men really, for them, the desire to be pregnant was about experiencing themselves as a pregnant, or as a changing body. For some men, it was about really wanting, not really, it was part of their desire to be pregnant and be a gestational parent, was about, or included wanting a different relationship as a parent, wanting a different relationship with their children, a more expansive relationship, the kinds of relationship that gestational parents are in one ways afforded, and in one way afforded, but also on the flip side, that gestational parents tend to be burdened with. And cisgender men really wanting a different relationality, and that being part of their pregnancy desires. Yeah, I think I will leave it there. So in terms of speaking about my research, so to conclude, to kind of, tie everything together, humanizing pregnancy-related care depends in no small part on a radical transformation of our ideas about pregnancy, sex, and gender, and the presumed relationship between them. It requires us to disrupt the feminization of pregnancy, and the construction of masculinity as non-uterine, as non-gestational. And this disruption and radical transformation of how we understand sex, gender, and pregnancy and the relationship between them must include our knowledge-making activities, especially where they are used to underpin healthcare practices. And in many ways, these ideas do underpin healthcare practices, our ideas of the relationship between sex, gender, and pregnancy, what a pregnant person is supposed to look like, the anatomy that a pregnant person is supposed to have. And it really is my hope that our recognition of the sex and gender diversity of pregnancy broadens to include humanity in all its diversity. So it's not just limited at a sex and gender level. But I think when we do recognize the diversity and of pregnant people and people with uteri, but also people who want to be pregnant, and when we expand our care, and when we incorporate this diversity into our efforts to humanize care, I believe it is then when we will have pregnancy-related care that is truly humanizing. Okay, thank you.
Wow, Jabu, that just completely blew my mind. That was wonderful. That made me think now whether even the word midwifery would still be appropriate. Because the word means with women. And what you're saying here now, to be as inclusive as we possibly can be, we probably even have to look at the definition of that word too. Yeah, so I'm happy to hear what others have to say or to comment. Jess? And then Helen.
I think I'll let Helen go first.
Hi, I'm sorry, I'm in a place where I can't have my camera on. Debbie, thank you so much. That was probably the best presentation I've ever seen on that topic. I myself am a non-binary queer midwife in the UK, and currently, hopefully not for too much longer, I'm the only gender inclusion midwife. And I just wanted to thank you for such a comprehensive sort of covering of the issues that are affecting our community, and for how clearly you sort of explored how the needs for our community, for the trans and non-binary and intersex community, are completely allied with those of cis women. So there is a significant problem, particularly in the UK context, with transphobia in general culture, but particularly within the birth world. And that has seen a real drive by TERFs to set cis women's rights as antagonistic to rights of trans and non-binary people in the birth space, so that obstetric violence is happening to cis women, and therefore any deviation of attention away from that is harmful, you know, for a movement towards you know, a rights-based approach to care for cis women. And I just really loved how clear you made it that all of us marginalized by cis hetero white supremacist patriarchy are allied and are oppressed in birth, because we are not essentially at present based on who can get pregnant, cis men, and so we are marginalized gender identities, although we're not minority gender identities, we are marginalized, and therefore it serves us well to unify and work together and see that reproductive justice is, trans liberation is inherently part of that movement, and that there is much in sort of feminist midwifery discourse that is trans exclusionary, and that is not, that doesn't move our efforts and our project forward together, and that unifying our movements and seeing how they are intrinsically linked, and that you know, by recognizing the sovereignty and sacredness of the ability to be pregnant, to parent, to give birth is in the process, and not inherent to any particular identity, which is not to say that there isn't beauty in specific identities' experiences of pregnancy and birth. So I wanted to thank you. And the other thing I wanted to add was I really appreciated your nuance around pregnant people versus pregnant women and people. I released some documents last year with a colleague about the move to the additive approach of gender inclusive language in the UK. So that's adding people to women, so women and people, birthing women and people, pregnant women and people. And that is not my personal belief that that is necessarily an appropriate way to move forward. And I think I just wanted to say that it's so important for people to recognise the context in which certain aspects of liberation happen. So that decision was made in collaboration with trans and non-binary birthing people, healthcare experts, and we had quite a lot of shock from particularly like US and Canadian academics around our decision, and it is very pragmatic. So there is a huge amount of transphobia in the birth world, and absolutely pregnant people would never would never be accepted at present within mainstream NHS, a socialised healthcare system. And we took a pragmatic approach as trans and non-binary midwives with our community at a grassroots level, that we would take essentially the least harmful approach to us, because we knew.
Ellen, I can sense your excitement about all of this, but we are on a time limit.
I'm sorry, yes.
No, but I understand your excitement, and thanks for sharing that with us. I'm going to ask Jess to speak now, or make her comments or questions.
Thanks so much. So first, I just really want to thank you, Jabu, for this work that you've done. I think it's very provocative, it's very important, and most especially, I think, for our learning, right? For folks within this space of, you know, intersectional scholarship and practice and lived experience, to be able to dialogue and think through some of these important issues. So I just want to foreground maybe one or two questions. So I work in the context of obstetric violence in South Africa, particularly, but also more broadly just around reproductive justice. And I think that, you know, obstetric violence has taken some time to really be identified as a gender-based violence, which in a way is surprising, but that has been more and more recognized in certain ways. Jason, I think in your earlier discussion raised how this is still something that is difficult to be piloted in our context, as well as others have mentioned. And obstetric violence is understood to be a kind of abuse and violence that's happening to people who are pregnant based on their pregnancy, as well as them being women, pregnant and being women. It's based on a kind of gender discrimination and hierarchy, which you, Jabu, have termed the patriarchal gender binary or system. And so I hear what you're talking about in terms of an inclusive language and terminology around birth, and those who are birthing, and not to actually distinguish between cisgender people who are birthing and non-cisgender people who are birthing. However, I am concerned about what the implications are of collapsing the very difference between cisgendered people who are pregnant and birthing, and the kinds of discrimination that they're facing based on those identity markers with those who are not cisgendered. I'm concerned about that. And I also want to understand from your perspective, or perhaps from the literature that was also, that you discussed, that lays this out, what they perceive.
Jess,
Sorry.
I think we lost Jabu.
Yeah, Jason. Yeah, indeed. Jason is right. Jabu went out of the waiting room, but I think they're back now. I just let them back in.
Oh, thank you. I'm also only on 13%, and I will be leaving probably after I hear the answer to the question, if I can even last that long.
I think Jabu is back.
Jabu, are you back?
Yes, I am.
Oh, great.
Thank you. So I don't know if you got to hear my question, but
No.
maybe. Okay, thanks. So I'll just, I also am having a blackout with electricity, and I'm on 12%. So I will just reiterate my question. So I understood from what you were suggesting that it'd be useful to only use inclusive language when we're talking about people who birth. Now, considering the fact that obstetric violence, as I understand it, as I think it has been correctly argued quite broadly globally, that obstetric violence is happening on the basis of discrimination because of pregnancy and because of discrimination based on female or women gender. And
We lost Jess there. So, Jabu, if you can hear me, I think Jess's question really revolves around the concept of obstetric violence being meted out to people who are pregnant and who are women. How do you include the people you refer to, cisgendered men, for instance, in that definition of obstetric violence and their likelihood of experiencing it?
Okay, I think I've understood the question. Okay, so I suppose one of my ideas and part of my thinking has been around understanding, so broadening our understanding of obstetric violence and how it happens or why it happens. For example, the overarching connection would be the devaluation of pregnancy itself, the devaluation of reproduction and reproductive labor, right? And that aspect of, or that underpinning of obstetric violence may likely persist regardless of the gender and sex identity of the person who's coming in, right? That's already being devalued. On the other hand, or at the same time, I've been thinking about how how patriarchy, right, utilizes the kind of devaluation of femininity and womanhood as the other vehicle of, kind of perpetrating obstetric violence. So in that way, someone who is not a woman, right, can still experience gendered oppression in an obstetric violence space. So I suppose what I'm trying to think through is that obstetric violence, I don't think it necessarily needs to be conceptualized as gendered oppression in a way that is specific to cisgender women.
Okay.
Gendered oppression would be, people who are not women can still do experience gendered oppression, even in a pregnancy-related space, right? By being compared and measured up as not women, or being expected to be women. It's just, for me, it's just about thinking of it a bit more broadly as a devaluation of pregnancy on the one hand, and on the other hand, as various kinds of gendered oppression. How are people gendered in that space? And how is that gendering used to oppress them? Whether we're talking about cisgender women, whether we're talking about trans men and masculine people, intersex folks, whether we're talking about cisgender men. It's, I think I'm hoping that I've been clear.
And I think,
I think, can you hear me now?
Yeah.
Okay, so Jabu, I feel like I understood that from your lecture, and that was very clear. But my concern is the suggestion to not differentiate at all between cisgender people and non-cisgender people who are birthing, because it seemed to me that if there was no differentiation about these differences, then we would be essentially ignoring the fact that cisgender women are being discriminated against and violated and abused in all sorts of ways. And as you rightly put it, so are others in quite similar ways, based on the fact of their gender, right? And so I don't see how just being inclusive and not differentiating actually helps us. I'm going
to stop you there.
Can I just make the one point?
We can have this conversation for hours.
It's fine. I'll put it in the chat. The one connected point.
Because there was somebody else who had a hand up, but I'd just like to get to them if you don't mind. Bahare, are you still there?
I'm there. Hi, Jason. Hi, everyone. I'm still here.
Good. You had your hand up.
Thank you for giving me the time for this question. My question actually related to the language as well. First of all, thank you for the presentation. That was really, really interesting. My question was actually very similar, where you say that we should use inclusive language and should not differentiate between women and other people. We have this discussion in the Netherlands, and I find it very interesting, and I don't know what language to use. I try to listen to the people that it concerns. The argument that is given for not erasing the word woman is because woman, being a woman, or the group of women or women as a term, is also a political term, and stands for the political emancipation of a group of people. So my question is, why should we, what are your thoughts on erasing the word or not using the word woman anymore? And wouldn't that exclude, like I understand that people includes women, but the word woman also has a political function, and wouldn't we lose that?
Thanks, Bahare. Jabu?
Thank you. Since your 2 points are very similar, I'll just answer them as one, really. Okay, so just to correct, in my presentation, I wasn't saying that we should not be specific. I wasn't saying that we should not use women at all. What I am saying, and what I was trying to say, is that we can be inclusive and gender inclusive, start from an inclusive perspective. So right now, a lot of our work tends to specify women, and by that it's often meant cisgender women, but tends to specify cisgender women and speak about cisgender women as if they're the only ones who can get pregnant. So pregnant people and cisgender women tend to be used interchangeably. And so the issue in this perspective where I'm coming from is starting from an inclusive point of view. Now, that doesn't mean that if I am now speaking specifically of cisgender women, that I can't then branch out to speak about cisgender women's specific experiences. So it's about inclusion and not exclusion. And right now there is a exclusion that's already happening. And that's the point that I'm making, that there is already an exclusion of the experiences and desires and of people who are not cisgender women. So the inclusion really is about recognizing that inclusion, writing in a way and conducting, practices in a way that recognizes the diversity, that doesn't stop anyone from then specifically focusing or addressing cisgender women's concerns. Specifically, inclusion doesn't mean erasure of cisgender women's experiences. I don't think it does. At the moment, there is an erasure of the experiences of people who are not cisgender women, and that's what inclusion is trying to correct. So I'm just going to quickly respond to Jess's comment. For me, there is a way to go birthing people, right? Birthing people. And then when I'm specifically talking about cisgender women, to say, for example, cisgender women's experiences are such X, Y, Z. So the issue of always tagging on women to birthing people, for me, and there are folks, trans folks and non-binary folks and intersex folks who don't have a problem with it. For me, always trying to speak about women or tag on women to these gender inclusive terms is something that we need to reflect on. But yeah, that's all I would say.
Thanks a lot for that, Jabu. I mean, clearly, what you're saying is disruptive and in a good way. And I'm pleased to know that women are not being excluded, or at least kind of covered by including cisgendered men. So that we now have time to go into plenary about everything that was discussed here this afternoon, or at least where I am this afternoon. And I would just like to know if anybody's got any burning kind of comments that they'd like to make about what we were exposed to during this sessions. Anybody? The floor is open. So we went around coloniality of power, knowledge, and being, what decolonization means for some. We've gone down the road of cisgendered men and pregnancy, and the desires that do exist for it, and how we collectively need to make sure that we include care that's appropriate for people who identify as such. So I'm happy to take any comments from anybody in the room, or are you all still very blown away?
We could also maybe take a 5-minute break and give everyone a little bit of time to reflect.
Okay, that's perfectly fine.
I don't know. I mean, if people have nothing yet.
All right. So, I mean, it's 20 past the hour. Shall we reconvene in 5 minutes, 25 after the hour? Okay.
Okay.
Cool. Okay, is everybody back? So the floor is open for any questions or comments, any ideas or any light bulb moments. Rodonta, have you got any comments to make?
Yes, maybe it's nice if everybody can turn on their camera again, so we can see each other and we can talk a bit together. I mean, I can say something, but I would love it if other people would say something. Maybe people that we haven't heard so much yet. I don't know if you would feel comfortable to share your thoughts from today. Also on the lecture that we had earlier, so about coloniality and decolonization.
Did anybody have the chance to see Dr. Chadwick's lecture, a pre-recorded lecture? Any comments around that? No?
Yes, Sanjana.
It's not like a big reveal or anything, but I just really enjoyed today's I mean, all the 3 sessions. And I felt like I'm yet to watch Dr. Chadwick's recorded session, but I felt like especially the coloniality bit, and also what we spoke about, the gender spectrum and to understand desires among different genders. I felt like it really spoke to Dr. Inge's session, that where she spoke of something. I think she said the epistemic firewall, if I remember correctly. And I think she laid down 3 things. I think it was normalizing, privatizing, and I think something else. I think naturalizing. And I felt like the last 2 sessions, I think they really spoke to the 3 things that she had, like in the very beginning, she asked us to rethink as to how when you think about care, you are supposed to think of what identities are naturalized, and how there are these assumptions about certain kind of identities, whether it's women or different kinds of genders, or Black or indigenous people. And then there's sort of this privatizing of care and treatments, where they say, like, this is supposed to be, this kind of treatment can be given to this sort of a person, or these kinds of identities. And I think it came up during some of our discussions in the breakout room, where we were, I think Emma or someone, I remember, they mentioned something about ethnic pains, in things like that, where you kind of like a racist way of assuming um, which identities or which communities can suffer more pain and things like that. And I think it really, the same thing I think was continued in what in the last presentation, in terms of the whole medical system and care providers sort of assuming on behalf of communities and genders as to what is right for them, and a certain kind of research and discourse sort of normalizing that kind of care and treatment. So it kind of really struck me that what she said on the first day, I think it really resonated like with me in the past 2 sessions. So it was really nice. I took like a bunch of notes. It was great. Yeah.
Thanks, Anjana. Thanks. Anybody else? Priya.
Yeah, hi everyone. Thank you so much. It was a great day today. I was just thinking that at CMS, and what those of you who have been part of the critical midwifery studies, different discussions that we had, I think this language and inclusivity of language around women and birthing people has been an issue that we have been talking about for a long time. So I'm happy that that came up in today's discussion. I was just trying to think along, and we all can think about it together, that taking whatever we've learned so far, right from relationality, coloniality, decoloniality, and now the question of inclusivity, I was just thinking how we can make the pedagogy of maternity care or birthing or midwifery, but how it all can impact pedagogy in a positive way, like what we take from here. So maybe Jason, if you have anything to share, because in the beginning you spoke about in terms of impacting even those 5 people in your class of 250. So I was just wondering that how these concepts can be brought in a more forceful way in the pedagogy of these different areas.
Priya, I think there's first going to have to be significant dismantling. A lot has to be dismantled. And if I just think in the South African setting, and it's just a pity that Jabu has gone, apart from the colonial aspect of it, the patriarchal aspect of what happens in this country is so disabling, because there's various cultural groups, there's various religious groups And even within the student population, those kinds of ideas and ideologies and things will need to first be not dismantled, because you can't really do it with individuals, but I mean, the way people think needs to be addressed, and values clarification, that is something that we need to look at. Valuing people for who they are, irrespective of what or however they identify, and putting humanity at the basis of everything. Your own beliefs, your own ideologies are secondary to the care that you provide. Yeah, so I don't know, it's just complex, but the first step would be to dismantle. I'm happy to hear anybody else's thoughts. Anybody, feel free. Jeff, go for it.
Thank you. I want to second what you said, and I was thinking about that actually before you brought up the patriarchy, because we had this conversation about coloniality, but there wasn't a discussion or the richness of thinking about that in relationship to patriarchy could have been deepened, I guess, from a certain perspective. And I thought about that in relationship to Jabul's talk, because he mentioned this issue of, anyone, once we have transplants available, anyone can have a baby, which in one way sounds like a great idea. But if you look at what feminists have said about patriarchy, it begins with this control of nature in reproduction. And so what I've seen is more this idea in medical sciences about, having free uteruses that can just produce babies without, a woman. So I think, we have to, even though there's a promise there of anyone being able to have a baby, we also have to be thinking about that other side. And that's where that pedagogy comes in, and dismantling the whole system. So I think we have to be very, or I would, caution somewhat about how we approach these issues, because it does seem like it's freeing, but it's the same sort of thing as twilight sleep, right? There's a give and a take at the same time. But I really appreciated how all of this came together today, and the beautiful thoughts there. And I think we have to keep thinking about those kinds of questions about the system and that sort of thing. So
and I think
thank you very much.
And we have to recognize that the answers aren't here now. It has to be mulled over and discussed. Claire, please go ahead. Your technology not playing along, Claire.
No, sorry, it's completely a user error. I beg your pardon.
No problem.
Yes, thank you so much for. I think you're absolutely right that the things, and it's been very, very thought-provoking today to listen, especially to the last presentation. It's been a long time since I've been in the world of really contemplating things outside of my own realm. So it's and it's exactly why I enrolled in this class, because it was the idea of being on the edge of my own thought processes and being challenged is, to me, just an excellent way to be. So thank you. What it comes down to is, for me anyway, that humanizing care is about recognizing and understanding the individual and setting up systems that accommodate that in a much better way than it does, and particularly maternity care, because we're dealing with women who, for the most part, are not ill, but we put them into a medical system to subject them to a standardization. And I think if anybody is at a good position to have the humbleness to understand understand the individual. I mean, you mentioned, Jason, that maybe we need to rethink even the term midwifery, but I don't think we do. I think we need to actually understand midwifery as it is. Sorry?
No, we're just throwing a stone.
Yeah, no, sure. But and I'm catching it. I got it. And I think I don't think we do. I think we just need to appreciate actually the depth that midwifery already has. I actually think that they accept all of these the individual. It's much better. It's in a much better position, I feel, to appreciate this diversity than many other disciplines, and probably the best, actually. And I'm celebrating, and I know there's lots of midwives here. So I guess those were my my thoughts, and thank you very much for listening to me.
No problem. Thanks for that contribution. Anybody else? Because I'm sure there are burning thoughts out there. No.
I don't know how to put up a hand on the Zoom.
Merita, go for it.
Okay. Well, also thanks a lot for today. It was very interesting. Okay, I don't know if I'm gonna do this in English, but one of the thoughts that just crossed my mind was about the term humanization. That it's something I thought about a lot, but that's like 5 years ago. So, but same as the term midwifery, I was with the talk about decolonization, I was thinking, like, how does the term humanization help us or not help us? Because especially within the history of colonization, the idea of humanizing another or having to humanize another is very complex. We have yet, geez, it's been so long since I've been speaking in English. I don't know, maybe just as a question, like, is the term humanization, how does that, is it helpful or is it not helpful? Because to me, that's also what would be defined as a human is very, has in the past been very restricted.
I get what you're saying.
Yes.
I mean, my thought is that it's just to bring the humanity back.
Okay.
And the diversity of humanity, that is what we're trying to get to. I mean, having to define what humanizing somebody is that is not what this is about.
Yeah.
It is about understanding, accepting, honoring the diversity of humanity and those we care for. So that's what it is. Not about defining what humanizing it is, what humanizing is. I mean, we've got long histories from all over the world for hundreds and thousands of years of how people were dehumanized. But I think as a discipline and as a group and as a collective, we need to bring it back to the care that we provide, and just to see humans for being humans, and to have the humility to accept them in all forms, and give them what is appropriate and effective for them in terms of care. I'm not sure.
Space for anyone to give meaning to what that means.
Yeah, that's right. And I mean, in one of the slides, I said for a space for anyone and anybody.
Okay.
Not anyone, one word, anyone and anybody. So to be as inclusive as we possibly can. I don't know if I make sense to you, Marta?
Yeah, I think so. Because that sort of leaves space for a conversation about what it means in this context or this context. So
it's about who walks in the door.
Yeah.
And they will get what they need from you. Okay. That's basically it. Or unless I'm up the wrong tree here, Rodante, Priya, Madaisa.
Yes, I think, no, I agree with you, Jason, but I like the question. It's a good question. It's also something that we've thought about, and I've thought about also. Of course, there is from the field of post-humanism and post-human studies a lot of critique on humanism, and also on humanization, or on what is a human and what has been understood as a human, and to use it indeed as a kind of suppressive term. But then when you look at post-colonial studies or Black studies, there has been a bit of a different tradition also of Black humanism, but also, for example, the difference that Sylvia Wynter makes between man and human. So she has this distinction between man with capital M, which is, she has a couple of different distinctions there, but the main one is sort of the biological white man that is defined in terms of economy and biology. And then she wants to transgress these borders of what it means to be man towards a humanness that is way broader than that. So she, for example, understands really humanity or the human as something that we have not reached yet, because we have not reached the full diversity of what it can mean to be human. And I would think that in CMS we use this term human in this sense. So not as the Vitruvian man, that is a white European man, but exactly as the human, which can be all kind of people and all kind of diversities of being human that we might not yet have articulated. So I just want to add it, but also I think it's very true that it is a very specific reaction to what happens in the labor ward, where people are severely dehumanized and objectified, and therefore it is important to bring, exactly like Jason said, humanity back into the space of birth, where actually a lot of humanity has disappeared.
Thanks, Vedanta. Yes, Majaisa.
So yeah, I think I fully agree with what Rodanta said last, and I think that it also connects for me to the discussion that was going on previously about the distinction for obstetric violence for women or not women, because I think this is what connects us, or both. It's the dehumanizing, and it doesn't matter what your identity is, but people are being dehumanized and treated badly. And I think that's what you want to address.
Any other burning comments? No?
But I do think it's a very interesting discussion to have. Like, we could also say post-humanizing birth. I don't know, I mean, it is, of course, it brings up, depending from which field of theory you look at it, it brings up many questions.
Absolutely. And I mean, this is something that can be discussed for days on end. Yeah, and as I said, the answers don't lie here. The answers are somewhere down the line. And it will be a collective effort, and everybody's own strengths and everybody's own thinking, thoughts, that will get us there. I see we've come to the end of the program. People, what an absolutely wonderful couple of sessions we had today. It was just mind-blowing, but also it begs more questions, and I love things like that brings more questions than answers, and enough food for thought to cause me a nervous breakdown if I think too much about it. Yeah, so I would like to thank our speakers today. I think they all have left. So Shanaz, Lance, and Jabulile, I want to say a massive thank you to all of them for bringing their thoughts to us. And I'm going to have a look at Rachel's YouTube video at some point, probably later this evening, after I've had some dinner. And I'd like to thank each and every one of you for staying the course, for your comments, for your questions, for participating, for being here, and being part of something massive that needs to shift. There's going to be a tectonic shift in maternity care across the globe. And the people in this room and the others that have been here early on are going to be instrumental in that. So thanks so much, all of you. And wherever you are, stay safe, be good, and have fun. So I'm going to say good night, goodbye, good morning, wherever you are.